Yeah. So we can see that there's a very clear trend on Thursdays and Fridays. It looks like those are very slow days. There's not a whole lot of intakes happening on those days. And then the peak day that shoots right back up is a Monday. And that's a trend that we're seeing just within this data set. We don't know if we expand this out, will we continue seeing that trend? But at least in the time frame that we're looking at, Thursdays and Fridays are slow days. Monday looks like a peak day. And that doesn't really give us a whole lot of information, right? That could be for many, many different reasons. Maybe that's on purpose. Maybe Fridays are more of an administrative paperwork day. Maybe there are fewer appointments scheduled on the books that day. Or maybe you have staff out on Fridays because Fridays are closest to holidays a lot of the time, too. So that could impact the number of intakes that might be completed in a given day. Or it could just be that people don't want to go to their provider on a Friday, and that's pretty normal, and that's a trend we see a lot. So just as a guess, why does anybody think we might call them a run chart instead of a line chart? Any guesses? I'll save you the trouble. So we're looking for a run. And I know that sounds obvious and it doesn't really explain a whole lot, but a run is essentially a trend, right? We're trying to see, is there a trend that we're following? Is there a control? And this will make a little bit more sense when we return to these in a future session, but just keep that in mind, the difference between a line and a run chart.
And we have Jessica typing something in the chat. Oh,
Yeah.
unless, never mind.
Okay. So a bar chart, this is probably one that you've seen many, many more times and you're very familiar with, but there are different ways to present it that can actually be a little interesting. So a bar chart can compare performance among categories of data. So there's different ways to present it. We can present a horizontal bar graph or a vertical bar graph. But in general, bar charts need to start at zero. They should have a zero baseline. There are ways to use it without a zero baseline, but the only way that's possible is when all of your categories of data are within a very close range of each other, which is not always the case. So that zero baseline is very, very important. So this slide shows an example of a horizontal bar chart. In general, for a horizontal bar chart, you need to have a zero baseline. It's usually used when you have data labels that are very long. So in this graph, what we have is it actually came from a provider survey that we issue out to providers each year. In this case, we're asking, how does your agency serve clients who do not speak English? And we had different categories or different responses available in the survey, one of which was hiring staff that speak other languages, having a language line, translating patient materials, having translators or interpreters when needed, other, and then they could indicate what the response was, and then not applicable because they don't serve any clients that don't speak English, or I don't know. So in this case, we can see that 94% of the agencies that responded to the survey said that they hire staff that speak other languages, right? So we start at the zero baseline, 94% of the responses. They could have also responded something about the language line or translating patient materials, but we know that a majority and a very, very much more than a majority said that they at least hire staff that speak other languages. So this is really actually better for large data sets, especially when those data labels are long, and it clearly shows a relationship between a large number of variables usually. This is different from a vertical bar chart. So you've probably seen a vertical bar chart before. It might look a little bit different. Whoops, I skipped ahead. So in this bar chart, the bars are a little bit fatter, so forgive that. But this is different because in general for a vertical chart, you want to have a zero baseline. It's a better choice for displaying negative numbers though. So in this case, you can actually go under a zero. And the height of the bar makes the comparisons very, very clear most of the time. The variable that you're comparing here is a percentage change. Oh, excuse me. Can't see my thing. The variable that you're comparing in this chart is the percentage change of new HIV cases among different age groups over a 4-year period. So we're looking from 2016 to 2020 and how the number of HIV cases across each of those age groups has changed in that 4-year time. The trends are very clearly visible. So as a guess, if you want to unmute or put in the chat, what do you think this graph is telling us? Remember, these are age groups. So 0 to 19 years old, 20 to 29, 30 to 39, 40 to 49, 50 to 59, and then 60 and up.
Keith
We need to be
responded.
concerned about age 60 and above because the trend is going way up.
Yeah, so when we're thinking about the fact that this is new HIV cases, we want to see a downward trend, right? We want to see this decreasing because we don't want new HIV cases in any age group. But it's especially concerning, like Charlene said, in the age 60 and up because it's increased, and not just increased, but at a very high rate. It looks like about 40, maybe 45% here. So that's alarming. That means that something's not right with our aging group, right? So we may need to dig further and look at this data a little bit more.
We have a couple of answers in the chat. Keith answers that there was a decline in new diagnosis in 0 to 19 population. And Yaite, younger cases are down, older folks are higher, or ADAP team. And Jessica asking, is this real data?
No, it's not. We made it up. But yeah, all great responses, all great feedback, and all very true.
And Keith also
right.
mentioned, he said, or that a testing program is focusing on just one age group and so receiving higher. Yeah, like if there's more testing at like nursing homes or something.
Yeah, so there's probably quite a bit you can infer, but without more information, it's definitely hard to say with any sort of certainty. But we do know that whatever they're doing at that agency is very successful among younger age groups from 0 to 29 years of age. So maybe we need to prioritize what's going on with our 60 and up. So very, very great insight. So we'll move on to when to use a pie chart, or usually a circle chart is what some people might call it. So you can think of these guidelines when you think of a pie chart. Do you have just one variable? So you're just looking at age, or you're just looking at income, or some other variable, but just that one? Can you sort that variable into categories? So if you're looking at age, can you break them up into age groups like we saw in the bar graph, age 13 to 19, 20 to 25? If you were looking at something like income, can you also split that up into categories? So say $10,000 to $15,000 in income. Is there enough separation in the data that the observer can see a difference? So if all the slices are the same size in the graph, you might want to consider using a different type of graph. It's not going to really tell you much if everything looks the same. If two categories are very close in size, you can also consider another chart. If you need to compare variables, pie charts are probably not the best idea to be used, but they can be used to compare the same variable over time. It's just not always the best way to look at it. And it's important to also remember, as a rule of thumb, a pie chart really shouldn't have more than 7 slices because it looks very, very confusing. And often there are not enough colors to represent any clear differentiation in the graph. So the rule of thumb, if two categories are close in the same size, consider another chart, or you can also reconsider, you can consider redefining the categories into maybe different age groups. So we'll take a look at an example. Let's look at this chart. It's a pie chart. It shows age distribution. So what's wrong with it? We're only looking at one variable, right? But there's still some work that can be done with this pie chart.
Jessica says too busy, and Charlene says similar colors.
Yeah, absolutely. It's too busy. So there are probably way too many categories. The categories don't look like they're consistently defined. Maybe that's a little picky, but that's me. So in some cases, we're looking at maybe a 5-year trend, and in others, it's a 10-year or almost 9-year trend. So that already does not really inspire a lot of confidence in the data. So the categories aren't consistently defined. It's visually confusing because there's a lot of different sections. And there's very similar colors. So can you really tell the difference between the 10 to 14 age group, the 30 to 34, or the 40 to 49? I can't, and I'm looking at a really big screen on this because it's all blues. There's actually, I think, another one that looks gray, but could also be mistaken for blue. So that's already too much. Visually confusing. Does it really tell us anything, right? That's the most important part. Does it tell you anything? Probably not, right? So how would you fix it? Any ideas? Be brave. It doesn't take much, right? We need to solve for these issues. Too many categories. So maybe we should consider reducing the categories, right?
We have some. Oh, I'm
Go
sorry. We
ahead.
have some answers in the chat. Keith suggested better grouping of the age population to reduce the numbers, and Jessica suggested to widen the age ranges and make them consistent.
Yep. And then consider the colors too, right? So let's look at this one. We've fixed the chart. We've reduced the categories by redefining the age groups, like you all said. We used different colors, right? We wanted to make sure we stayed away from colors that were similar so that didn't cause confusion. And now we're only looking at the same one variable, but we can really tell the weight of the variable on the data distribution. So this pie chart gives you a better idea of the patient population. The percentages show, like I said, the weight, and you can consider the message that your audience consider your message and your audience in choosing how to represent these numbers. So now that you look at the exact same data, just distributed a little bit differently, what stands out to you? And if you can't see the age groups, it's 10 to 19, 20 to 39, 40 to 59, and 60 to 80.
Keith responds that nearly half of the population is 60 plus.
Yep. Yeah, definitely. So we know just by looking at this data and nothing else that more than half or almost half of the population is over the age of 60, 45%. So what might this tell us about how we design or how we deliver our services? Let's pretend we're also considering the data from the last bar chart that shows that there's an increase in new HIV cases among the 60 and up. So that
We have some
question again
typing in the
was,
chat. Oh, sorry. Oh, just waiting for typing in the chat. Keith says we would want to emphasize medications and medical visits to accommodate multiple specialists for an aging population. And we have some typing focusing on the aging population.
Yeah, absolutely. So you might want to consider, if this was your agency, that you might need more services for people who are aging with HIV. You might also need more services that are specialty care services for conditions that are related to age. You might need to develop relationships for those services as well. You may also need some more support for technology because as things like telehealth become more accessible and more available, we know that there's a growing segment of our patient population that's not really a reliable option for them, or they need a lot of help to be able to access it. And then just like Keith mentioned, you might actually need some more client education materials on HIV and aging or conditions that are related to age, especially for those who might be at risk of HIV. So great job. You can also combine charts, and this is very, very useful when you're trying to compare different categories of a single variable to a separate indicator. So in this case, we're comparing the age that we saw in the previous pie chart. So that same pie chart, but just broken up in a graph, which, by the way, you can do that too. It just has to make sense for the data that you're looking at. So we're looking at the same age group distribution from the pie chart against viral suppression. So the bars represent the age group and then the line represents the viral load suppression of those age groups. So what is the data telling us here? There's clearly the same problem, right? The problem is viral load suppression rates are lowest among our 60 to 80-year-old age group. So we really need to focus on those clients. So any questions before we move on to understanding types of data? All right, if not, I'll go ahead and turn it over to Mika.
Okay. All right. Hello, everybody. So we're going to be going over the differences between quantitative and qualitative data. This is a pretty short section. I'm sure most of you are already very familiar with this. So we'll be starting off with describing does anyone want to just drop in the chat before we start? What is the difference between quantitative and qualitative data? And we'll wait for the typing.
Hi, yeah, quantitative is the amount, qualitative is the, kind of yes or no kind of answers sort of stuff.
Okay. Okay, so yeah, I can see that. So yes or no, I think can also end up being quantified, but it is like the more verbal responses. Yeah. Charlene, quantity is numbers, and qualitative is story. I come from an anthropology background, so I think of it that way too. Qualitative is kind of like the story that gives the reason for the numbers. Keith, qualitative is the more detailed interview, individual level. Quantitative is more bulk. Yeah, that's a really good way to look at it too. Oh, sociology. Nice, high five. But yeah, that's a great way to look at it too. So looking at kind of the more individual versus a bigger picture of what's happening to everyone. Okay, great, awesome. So starting off, we'll just go over quickly what is quantitative data. As everybody said, quantitative data are numerical values. They typically answer questions of how many, how much, and how often. So some common quant data that you all deal with in your daily life: 200 copies of HIV, of course, checking how many people attending a training, finding how many no-show appointments happened during a week. Quantitative data is recorded very differently than qualitative data. It's often recorded through data input and recording systems. So that would include like electronic medical records, things like Careware, Athena, or internal spreadsheets as well. And this kind of data offers more objective findings than just qualitative data, but it can often be missing the why to it. So we can go to the next one. Or actually, does anyone want to give any examples of quantitative data that they've used recently or that they often, think about? Okay, so one thing that we always use is lab values pretty much. So constantly checking on these lab values over time. Even as case managers, very easy to just check and see, oh, 20, going up to 76, going up to 150. Okay, great. Let's see, we got a suggestion. The SFPC peer survey would be a qualitative data type. Yes, and we'll go to that, and whoever's typing, just keep on typing. So our qualitative data is data that can be observed and recorded, and these data points are often collected through surveys, town halls, meetings, the in-depth interviews that Keith mentioned, as well as just observation. So even just sitting down in the waiting room and just paying attention, oh, where is the mess up in the flow? Does it take too long? Does the COVID screener talk too much? Paying attention to those kind of things. Qualitative data are often descriptive, non-numeric, and as we said, it can be used to answer the question of why. And this type of data helps provide context to an outcome. So some examples of qualitative data: my case manager regularly takes 2 weeks to return my voicemails. And so that type of qualitative data can provide context to, for example, no-shows or things like that. People are trying to reschedule, but they can't reschedule. Another example, I can't get to my voicemails because I have to spend an hour a day filing. And so that provides us with a lot of context about process. And then last one, clients report that they feel stigmatized by a certain provider, so they won't attend appointments with them. And so this is where the qualitative data really starts becoming extremely, extremely useful, is because that type of information will literally almost never pop up in something quantitative. So it's, as we move on to our next slide, we can just talk a little bit about how quantitative and qualitative works together in harmony. So qualitative, so bringing together both types, really all data presentation is very effective when you can contextualize this quantitative data. Aside from just adding data labels and things like that, if you have the opportunity to present your data, then adding in that qualitative really provides a lot of support. And backwards also, the quantitative data also provides support to anecdotal evidence. So if you often are hearing, if the first method of your data collection is people coming to you and constantly complaining about a certain thing, we can start looking and collecting quantitative data in order to support that. It also helps by bringing the both together. It helps the audience to brainstorm causes and solutions. As we saw in our previous examples, some of them were missing a little bit of qualitative. Like Keith said, are they focusing this testing just on older populations? And by bringing both together, we can also help to resolve gaps in the data. Is there anything anyone would like to add or anything around quantitative and qualitative? Okay, so we'll go on to our making data meaningful. So of course, when presenting this data, we, as Yasmin was saying, we want to make sure that we are thinking about our colors, thinking about what type of charts that we're using, and thinking about what exactly are we presenting. So are we just presenting initial data? Is it just what we've collected at first? Or are we presenting the result of changes over time? Are we displaying an actual process? Are we explaining how a workflow is? Or are we showing what is the result of a change? So some example, as I said, so work process and workflows, patient check-in procedures. Are we just doing static numbers? Are we identifying improvements, or are we identifying negative outcomes? Because then that, of course, is also will go into how you want to present it. And is this an outcome of a process change, or is this simply introduction of a new process? So we want to think about also, you can go to the next slide. What are you trying to convey? So when we think about, so what data are we presenting? Okay, well, what are we trying to say with this data? So an easy question, an easy way to kind of parse this down is which step in the PDSA cycle or in your general QI process does this data relate to? So like I said, is this initial data collection? Is this in the planning? Are we already looking at the study aspect of it? So are we now presenting the outcomes of what came out of our due cycle? Or are we looking at solutions? So are we taking our data and presenting solutions for that or potential future trends if things don't change? And does anyone have any questions or anything around here, anything to suggest or things they think about when they do data presentation?
Nothing in the chat.
Okay. So, and then of course, we always want to consider who is your audience. So you want to consider what is your audience's familiarity with your actual data compilation process. People like to know where these numbers are coming from to make sure that, you know, maybe their agency is not checking off a box or something like that. We always want to, and we want to try to provide that explanation. Contextualizing quantitative within qualitative data. So again, remembering who your audience is this audience that is very familiar with this and can just go straight through the numbers, or do we need a little bit of background to explain what's going on? Is this for internal use or is this public facing data? So are you planning to just send this out to your case managers or your planning group, or is this data supposed to be presented maybe on a bulletin board or something like that on a poster? And of course, always considering accessibility concerns when you're formatting your data. And I find that this is very important to make sure you think about the size of your numbers. And as we mentioned with the pie chart, similarities and things like that, the saturation of your colors, and other concerns around your audience. And hearing, of course, if you're doing hybrid meetings and things like that, it can be useful to simply record it as well. And even some meeting softwares, they have transcription services that are free and available through that. So any suggestions around audience or anything that people think about? Okay, if anything, just drop it in the chat. And of course, thinking about what resources are actually available. So always now in this world of COVID, thinking about our physical versus technological considerations. Is this data that is supposed to be printed out? Is this data going to be saved in a certain style where other people can print it out or they can make edits to it? Again, is it internal use or is it public facing? And technological considerations, are you just sending this spreadsheet out with no context? So does there need to be an extra bit of context there? Some charts also are much better adding some animation to it, of course, having things building up instead of simply the whole chart at once. We'll have an example of that later. And of course, recording meetings, like I mentioned, when appropriate. So those are some things to kind of keep in mind around presenting data. So we'll go through some examples now. So I think we have 4 examples ending with one of our submitted data sets. So thank you very much for submitting that, our ADEP team. So starting with our first example of a data presentation. So those of you who go to Planning Council might recognize the next slide. Here we are looking at our food bank service. We're looking at the fiscal expenditures as related to client utilization. So we were looking to see how much money was spent out of this budget and how many clients actually accessed this service. So in this case, we are presenting two different types of data, financial data and utilization data. And so this context, so as we go to the next slide, we'll see that contextualizing the data tends to be more communicative. So we are looking here and we have a simple bar chart and along with a bar graph, and along with a simple table underneath. And so that provides additional access without making, additional information without making the actual chart, the graph itself too busy. And so we see here on the chart, we see our number of clients that actually access this. And we see our time here along the bottom. In our table, we see the inclusion of our expenditures, our clients, and our units. And we actually see the percent change at the bottom, so 15 to 18. And so, for example, when presenting this data, that might bring about some concerns. Oh, there was a drop in food bank access. What happened? It's not that clients all of a sudden are no longer hungry. So we add some context. So Q3 is the quarter that hits right around Christmas. And so a lot of agencies provide their own Walmart gift cards and things like that go on. So there's utilization that goes down because agencies are providing their own services and clients are also utilizing those. So that's how we kind of combine those two when we present. Let's see, are there any questions around this first example? Okay. So our next example is a much more complicated chart. And that's because this chart is going to an audience, or I'm sorry, this graph is going to an audience that has a little more familiarity with some of these. So in this example, we are looking at viral load suppression over time for one specific group. Well, for a specific category. So in this one, we are looking at age in the Orlando EMA, and we're looking at changes in viral load suppression across different age groups. This one is only looking at two separate time periods. So as I said, we're presenting this data to an audience that runs their own reports. So we can be a little bit more complicated. So this next chart is one of the ones where we built in the animations and it does build up. So we have at the top, we have our disparity category age. At the bottom, we have where is the area that's getting collected. And as we click through, we see it start building up. So this is it has two different vertical axes labels. So on the left side, we see our total clients by age, and this is one of the combined graphs that Yasmin was talking about. So we'll show the total clients by age, which is referring to our bar graph. And on our right, we see our percentage of clients, which will refer to the line graph that is coming up. So as we start building up, we can go ahead and start clicking. So we see our age comes in first. So we see our age, our 18 to 28 range. And as we build up, we can keep clicking. And so we have our we have our bar graphs coming up first. Once you see the end, you'll see that it is a very busy chart. And so this is something that's difficult you don't want to just throw this in someone's face. And so we see the data labels inside so we can see exactly how many clients are there and how many clients are actually being served. So we're looking at a total of 467 clients, for example, for age 18 to 28 in 2021, and then 375 clients in 2022. So that's the total clients. Then we want to see what is the percentage that is changing across. So we can go ahead and click to the next one, and that introduces the line graph. So we see our same category, our 18 to 28, they were virally suppressed at 87% in 2021, and then 88% in 2022. So, and as we keep going, we'll see it gets very busy. Now, I wouldn't say this is necessarily the most effective way of showing this, but for example, for our purposes, we have, a limited amount of time to present this, and showing a different graph for each individual subcategory of the group also would not necessarily be effective. So it's a little harder to read, but when you know that you have an audience that is more comfortable with this kind of data, then you can get a little bit more creative. Are there any thoughts or anything like that around anything we've shown so far? So our example 3 is a process flow. And so this is a little bit different than and different way to present our data. So in this one, we are presenting qualitative data, and this is reflecting process to access a copay assistance. And so this flowchart is showing the required tasks that must be completed, as well as the assignment of who needs to complete this. And this data specifically is to be used as a training tool for referral staff. And so we can go, so we see this one, we also build it up also. So for example, let's say that we are trying to train staff to ensure payer of last resort by billing the appropriate category for the appropriate services, right? So if we're looking at medication that is on an ADAP formulary. So then the case manager walks through the flow chart. Is the client enrolled in ADAP? Then the client provides the pharmacy with their copay card they received from ADAP. Then the pharmacy will process the payment via copay card. However, if the client is not yet enrolled in ADAP, then the case manager has to submit the referral to ADAP, and it includes documented in case notes. And then what are the two options from there? The case manager applies for the patient assistance program if applicable, or if no PAP is applicable, then it offers another option for billing and helping the client. And so when presenting this kind of data and collecting this kind of data, it also helps to really identify where are those breakdowns and find out exactly what is going on. So maybe the breakdown might be that client case managers don't know what patient assistance programs are. And so that's, even though it's at the end, it's something that can still be adjusted to make the whole process smoother. Okay. So our last example is on our data set submitted to us by our Brevard team, thank you so much, of unsuppressed ADAP clients. And so this is quantitative data. The presentation of this data will really depend on the purpose of this data collection. So are we looking for clients who are unsuppressed based on their racial disparities? Are we trying to demonstrate that there is a relationship between ADAP enrollment and being virally suppressed? So the data that was submitted, we see here, we have different test dates. They're all recent in 2022. So nothing to be concerned about that. But we look at our test results and they're very different. They're very, very high and very low. We have some clients who are quite low, almost undetectable, and then some clients who are extremely high. We look at our gender. We have a little bit of a mix there. Our race is, everyone is the same. And then our age also has a little bit of a mix. So the next couple slides, we're just going to present a couple different ways that this data could be presented. So in this first one on the left, so that was a clumsy attempt to try to show everything on one slide. And so graph or table, sometimes there are so many tools on here that we really want to play around with it and we just want to try to force things into what we're comfortable with. And sometimes the simplest way is the best way to do it. So on the left, we do see kind of a breakdown. We see the categories on the bottom, but I personally find this a little bit hard to read. However, a simple table for such a small group of people kind of makes it very clear because we're looking at numbers that are fairly small. However, and then if we want it, but that's to present the data in total. If we wanted to start breaking down this data, so we can go to our next slide where we've looked at it by gender and by age. And so we see our by gender, and so we have a pie chart in that one. And so we can include the actual number, so the number 2 and the number 5, if you would like. That's an optional thing. You don't have to include that, or you can just include the percentage. Since this is such a small group, the denominator is only 7 people, it's useful to have a kind of context for how much the total is. We can also look at the information that was presented to us by, or sent to us by ADAP by age. And so we're looking at viral load. And so in this one, I also included gender by making the 2 female dots yellow. So we can see that, and if we had a little more data points, this might be a little more useful if there's some more consistency, but it's a not creative, but it's a different way to kind of start visualizing things. So we can kind of see that for the most part, it looks like about half of our clients are they're detectable, but they're manageable. We can get a hold of that. And then the other two are super, super high. And we have someone who's also pretty, pretty high up there. But so this allows us to kind of provide a grouping a little bit easier without having to worry about the element of time the way that other line charts do. That's a scatter plot. So those are some different ways to present the data that was sent to us by ADAP. And so I'll stop here and see if there's any questions or any suggestions or anything that you all like to do when presenting data or anything like that.
I'll also add that, it's not necessary to combine different types of data on the same graph. It can overcomplicate a graph very quickly, so you have to be very intentional about what makes sense. Do you really need to compare those different kinds of variables together? Does it help the group make decisions? Does it help them have a clearer understanding of the message that you're trying to convey? All right, so I'll go ahead and continue on. Fix my screen. So we're going to move on to how to use performance measure data to identify problems or really analyzing data. So when we determine a performance measure, we know that measuring performance is required from PCN 1502. If you weren't here during the last session, PCN 1502 is our clarification guidance that's given to us directly from HRSA, which is our federal awarding agency. And it really outlines everything that you need to know about quality management, quality improvement, what is required, what is not, how to identify a plan or how to have a plan, how to identify infrastructure. It's really great guidance. So if you did not have a chance to review that since the last session, please take some time to do so. Most of the last session covered the elements of PCN 1502, but it does help to read the actual language. Once the quality management plan is set and priorities have been identified, performance measures help to put the plan in motion. To measure an element of care or process or an outcome, we often use indicators to assess performance within a particular area of focus. So indicators are often quantitative measures, so numerical measures that can be used to assess and improve performance. So I'll show you an example of an indicator. Indicators are usually chosen to reflect key aspects of care, which can impact the patient outcomes, and they can either be clinical or service-oriented, but they don't always have to be. Indicators can be grouped by the type, and they can address issues such as accessibility, the appropriateness of care, how effective the care is, and continuity of care. So an example of a performance measure indicator and an indicator type is provided on this slide. With today's materials, we're actually going to be sending out a handout that provides examples of other indicator types, performance measures, and indicators. It also identifies potential data sources for each of those. So on this example, we have the indicator type, we have the performance goal, which is our measure, and this measure is related to accessibility. So we want to know all the new patients will be provided with a medical appointment within 2 weeks of their referral. So the indicator for this is the number of days that elapse or the number of days that occur between a new patient's request for a medical appointment and the actual date of the appointment. And that's what we're measuring here. That's our indicator, right? And it's going to tell us what we need to know, whether there are, whether the patient is linked to their medical appointment within 2 weeks of their referral. Whether they actually make it to their appointment or not, we don't have that information yet, right? But once we do measure this indicator, it'll give us a good idea of what that looks like. So when we define measurement in a when we define performance measures, we also have to consider our population and our eligibility criteria. So the first is we have to define the target or priority population. We try to stick away from using words like target. So when we identify a priority population or a population that we're really interested in measuring, we have to decide who's going to be part of that measurement group and who is not. The second aspect is we have to consider timing. Are we going to be collecting the data as the patient enters into care and presenting that? Or do we want to follow their services for a period of time, maybe 3, 6, 12 months before we start looking at the measure? Patient characteristics also need to be considered. So are you looking at demographics like gender, age, the site or location that they're receiving services at, or maybe that they live in? You can consider housing status, insurance status. That's more more applicable to case management services. You can also consider their treatment status. So this is also helpful when you think about things like whether the client is indicated for PCP prophylaxis, for instance, like what is the state of their condition or their disease. When you consider data collection methods, you have to consider several questions. Is the data already available in some form, or do you need to manipulate it? Do you need to reach out to people to figure out where to get that data? Is the data collection process feasible? Meaning, is it achievable without a whole lot of effort? And is it not overly expensive? Data collection can cost money depending on the kinds of tools or the kinds of software that you might be using to collect data. Thankfully, a lot of the data collection that we do in our Part B service network is free thanks to Careware. But if you have an EMR, chances are your agency is paying for that EMR, so there is a cost associated with that data collection and data entry for that matter. You also want to consider, is there a faster, easier, or cheaper way to collect this information, and can you use that? Will the data be useful, and will it address the performance measure? Will the resulting data be credible? Is this something that we can rely on? Is this something that can be believable? Once the answers to all of those questions have been outlined, the data collection sources, the method, and the process should be documented in the QM plan, right? And revised periodically. If there's a new change to the data collection process, that change has to get recorded in the quality management plan. You also want to consider data sampling. So sampling is a very simple, very efficient way to understand how the system is performing without having to look at your entire 100% of your population, especially when you consider certain agencies have lots and lots, a big population. So sampling allows us to make presumptions about the larger population based on a smaller subset of that group. So we're using that smaller subset to estimate what might be happening in the larger population. So the number of eligible, and this is not like a Part B notice of eligibility type of eligible, but when we consider who's included in the measurement group, this is what we mean by eligible cases. So this determines the size of the sample. So one example of this is you want to improve viral suppression rates by ensuring that clients are linked to the services that they need to stay adherent. So what you decide to do at your agency is you want to monitor the completion of needs assessments each month for clients at your agency. But let's say that you have a total number of 1,000 clients at your agency. Does this make sense? Are you going to be checking every single one of them for that needs assessment? Probably not unless you really don't have any other tasks on your day-to-day responsibilities, and that's very, very unlikely. Most of us cannot afford to spend that much time monitoring for one indicator, right? One type of measure. So are you going to sample? Yes or no? I'd say this is a very good example of where you would definitely want to sample. So just as a guess, what percentage of the total clients in this scenario do you think is appropriate to sample? Remember, we have 1,000 clients. So what would be a reasonable effort when we consider we want to monitor the needs assessments every single month for a sampling of clients? I don't see the chat, just in case.
Oh, sorry, I was muted. We have some responses in the chat. We have ADAP team
10%.
responding 10%, Keith 1 to 10, Jessica 20, Nigel 10.
Ooh, y'all are ambitious. Remember, this is 1,000 clients. So even if we're thinking about 10%, that's 100 clients per month. And if that's the only indicator you're looking at, maybe that's possible, especially if that's split up among multiple people. But if it's just one person doing it every single month, it's going to get real tired real quick.
Jessica corrected to 20 people.
Oh, 20 people. Okay, thanks. More
And
towards
Keith
1%.
suggested.
Okay, yes. Okay, that makes a lot more sense. Thank you. Not to say that you can't, you could, very, very much you could. But yeah, I mean, I would think that a reasonable effort here when you consider 1,000 clients every single month that you're serving, then you'd probably want to stick more towards 1%. You could even get up to maybe 3% and have up to 30 clients, right? Especially if you're just looking at this one thing. But usually we're not looking at tools in that same way where it's just one monitoring indicator on the tool. There's usually many more indicators that we're looking at. So you might want to keep it anywhere from 10 to 30 clients per month. That's definitely reasonable. So great job. So just a quick note, for programs with a small number of HIV positive clients in this same scenario, like let's say you have less than 100 clients that you see per month, then maybe something closer to 100% of a sample is desirable and it's also feasible, right? So that's not to say that that same one person should be reviewing. If it's, let's say, 78 clients per month, that's still probably a lot of effort, but maybe your data systems, your programs, software can help you do that much easier. And so it's important to remember that your quality management project is not research. You're just trying to establish a snapshot of the performance in the most current point in time that you have available. So another thing you'd want to consider is random sampling. So this is a method to assure that each record has an equal chance of being included in the sample and being selected. So you want to make sure that you're applying random sampling wherever you can. Some organizations have sophisticated software programs to generate a random sample or generate a random client list. Others may have to manually select the sample from a printed list of eligible records. Many spreadsheet programs also have little features to have like a random number table to assist in that process too. So there are definitely ways to make sampling much, much easier. But even if it's something as simple as taking a list of clients that were served in the previous months and handpicking a random group of those clients. But then, you also want to consider the next month, is there an equal chance of picking a different client that month, or will you have a chance of picking the same client? So random sampling is especially important here. You also want to consider your data sources. So potential data sources of data that should be considered include the following. So clinical databases, medical records, paper or electronic, client-patient satisfaction surveys, client-patient intake forms and questionnaires, billing records, client-patient staff interviews, that's especially helpful, client comments, suggestions, complaints, laboratory databases, case management and social work records, or scheduling programs as well for a software if you have that. So when you consider analyzing data, you want to make sure that you're identifying areas where additional data is required. If historical data is available, use it. Compare for trends. Even if you're just using the most recent year worth of data to establish your baseline that you're going to measure against. It's always super helpful to look at data that way if it's available. You want to display and distribute data to communicate your findings and your results, and you want to identify areas for improvement and select a quality improvement project. So when you're analyzing data, if historical data is available, this is generally useful, like I said, to compare trends to help identify opportunities for improvement and to assess the severity of the problem. So in this example, we have a run chart that's essentially just a line graph that's plotting over time the percentage of unkept appointments, right? So we don't want this percentage to be high. We want it to be as low as possible because we want to make sure our clients are keeping their appointments. And this is apparently very old data from 2002. So in this case, we see that it starts somewhere around maybe 28% of clients are not keeping their appointments in January, right? And each month, that measure is changing over time. Those data points and observations are changing. So we see that this is a downward trend. This is a good thing. It looks like at some point it was climbing back up and then they decided to implement some change, right? Because this wasn't good enough. They wanted to show more improvement. So they implemented reminder telephone calls to be able to assist the clients in keeping their appointments. And then we can see that it had a very clear impact on the percentage of clients who didn't keep their appointments, right? We saw that this improved. But we saw that as of August, something might have changed, right? Because it's starting to climb again. So now we can see that there's a clear indication that there may be a problem here, right? We want to consider looking at this again. When data doesn't change across a period of time and it stays pretty consistent, that doesn't necessarily mean that there isn't an opportunity for improvement. Sometimes we can still make improvements, but often improvements can plateau. So we have to consider process. We have to go back. We use our PDSA cycle, principles. We use those QI principles and see, have we done enough here? Is there something that we can go back and refine and maybe test to see if it results in further improvement, right? But if you continue to see this line going down, then clearly we know what we're doing is working. So we don't want to, rock the boat here. But like I said, in this case, this scenario gives us a pretty clear example that there may be something happening now, right? Because we're seeing this slowly start to climb back up. So what's happened, right? We don't have enough information from this run chart to actually be able to answer that question, but it does offer an opportunity to explore an opportunity for improvement. So in summary, we want to make sure that quality improvement always starts with data. You want to think about how your data is displayed, the message that you wanted to convey. Remember those 3 buckets of PCN 1502, charts, graphs, whatever you want to call them. They're all important communication tools. The message that you want to get across is the most important thing. So you have to understand your audience, like Mika was talking about. You have to understand what you're trying to tell them. And you want to try to tell them in the fewest words or the fewest data points possible. So where we showed you a graph that was especially complicated, it was because it was easiest for us to layer that data over the other because that audience is, like she said, comfortable with data. They know what they're looking at. They know that we're trying to assess the change over time, but we're trying to keep it simple, right? We want to use as few data points as possible. So we didn't include data from 2020 or 2019 or 2018 because that's old news, right? Unless we want to see the change over time and see a trend, it's important to have as few data points as possible to still get your message across. And just as a side note, you know, the average attention span when someone's looking at a graph is anywhere from 5 to 7 seconds. So that's really the window of time that you have to communicate your message. So very important to consider, you know, the styling, consider the audience, consider how many data points, consider whether the graph or the chart that you're using is the right one. And you can always play around with it, right? Just because you put it in a bar chart doesn't mean you can't take the same data set and throw it in a pie chart and see what it looks like, right? And if you're ever not sure, ask the folks who are looking at this data, ask them what looks better, right? Not just looks better, but what makes more sense? What is this telling you? And that's a really, really great way to get that indication of we need to change up how we're looking at the data. If right now all you're looking at is tables, that's totally fine. Like Mika said earlier, there's lots of great examples of when that's most useful. We don't have to put everything into bars and charts. But when you do use a table, right, you also want to stick to the same principles, using as few words or data points as possible, right? Don't make it too clumsy. Don't make it too cluttered. Think of the formatting. Is it one big wall of text and data in a table? That's often really overwhelming. People don't really see what they're looking at. It's hard to see trends over time that way if that's what you're trying to measure. So important to keep all those things in mind. The more clear the message is, the less interpretation that someone has to do. So we're kind of cutting it through a little close this session. Before the next session, it'll be really important for everyone to look for a data set if you did not get a chance to since the last meeting. We want you to use real data, your data. So using your real performance data from your agency, if you haven't identified a performance measure, we can work on that together. Just let us know. But using that data, we want you to create 3 charts, a line chart, a pie chart, and a bar chart or bar graph. If you don't have data, we can help. We can give you a sample set. We can also give you access to Excel if that's something that you don't have access to, or if you just need help with it. We can always help with that. You can help walk us through what you think we might need to do, and then we'll work on that activity together. So our next meeting should be sometime in the second week of July. So what we're asking is for the previous week by Friday, July 8th is when you submit your data set, but also your 3 charts for homework. And come prepared to look at least one of your charts with the group. We probably won't have time for all of them, but just one of the charts with the group and present a possible problem. So look at your data in that way. Have that, you know, consideration in mind when you're thinking about it. And if you need any help, please feel free to reach out to either me or Mika for that. We're happy to help you with it. So that pretty much brings us to the end of today's session. Is a little bit shorter today, and we know, but we didn't want to make it too technical because it was a lot that was covering, especially with data, and that's not always the most glamorous thing to learn. But it'll be super important to develop that foundation, because as we look at next session or the next session after that, we're going to start using that data, prioritizing things and using special tools that can help you assess what to do with it, right? How, if you've identified a problem, what's next? So really important to us that you share your feedback about these meetings. You can either scan it with your phone if you want to just pull out your phone real quick and scan the QR code, or you can just go to www.menti.com and you can enter that code. You should be able to complete the survey. It's very short. I think it's only 4 or 5 questions. And that would really help us because we want to make sure that these sessions are really meaningful for you all, and that we tailor them to meet whatever training you're looking for. If there's a special topic that you need help with, we have sort of a schedule outlined for what this is going to look like across the next 8 to 10 months, but we're definitely open to any feedback that you have. And even if you don't really have any suggestions for us, if you just like how things are going, let us know. That's also useful for us as well. Mika, did you want to add anything before we?
No, just that I dropped the link in the chat for the Menti, and we really appreciate everybody's participation today a lot.
Yeah, thank you. And yes, Charlene, we'll provide a copy of the slides. We'll also be sending out the handout that I mentioned a little earlier. That's going to be really helpful if you need to look at your data sets and you don't know exactly what kinds of indicators you should be looking for. It'll give you lots to consider, especially if you're not directly working with clients or doing direct services. So we'll send out the materials. Are there any other questions, comments? We'd love to hear from you. Okay. All right. So with that, we'll go ahead and give you back the rest of your morning. Thanks again for joining us. It's helpful to hear from you all. So please continue coming back. If you feel that there's someone at your agency who should be on these meetings and isn't, let us know. We are always happy to identify additional QM champions. All right. Have a great rest of your week. Happy weekend. Please stay safe.
Hey.
Thank you. Bye-bye.
Bye, guys.